Hi, everybody. So really excited to be here with you all. I've worked extensively with gender and sexual minority patients, including throughout the Pacific, and I'm active at the organizational level throughout the American Psychiatric Association and other groups that work in this space. And I've worked as a sex ed teacher and currently work as a gender affirming care provider, helping with the qualified mental health provider side of things, making sure people are on economically, socially, kind of like unstable ground before they proceed with any kind of big change in their life, but especially as it relates to today, on things like their gender journey. And if they look to change, say, their name or other parts of their identity, making sure that they're in a good place to do that and they're approaching that wisely. Nobody pays me. I wanted to set a few objectives here that we could kind of look at the diagnostic manual and kind of how they see gender and sexual minorities, specifically looking at the newer construct of gender dysphoria, thinking a little bit about what's like the transgender identity and what is gender dysphoria and what distinguishes those. Try to look at the prevalence of things like gender dysphoria in the Hawaiian young people and then kind of look at the importance of this interdisciplinary approach that's really come to dominate best practice in this space. So, gender dysphoria is this conflict between a person's physical or assigned gender and the gender with which they identify. People with gender dysphoria might experience a lot of distress or problems functioning because of this conflict in their gender assigned at birth and how they see themselves in their inner view. So this experienced, expressed gender might kind of have some tension or disagreement with their physical assigned gender. When you look for young people and doctors start to wonder if there's gender dysphoria here, we can start just kind of looking at the DSM, the Diagnostic Statistical Manual, as it identifies gender dysphoria in adolescents separately from adults. So what we're looking for here is a difference between one's experienced gender and their assigned gender and distress for at least 6 months with at least two of these. So we're looking for like difference between expressed gender and biological sex, a desire to be rid of primary or secondary sex characteristics, a desire to be treated as the other gender and gain their characteristics.
Doc-
Observations,
Dr. Lee, we're
yes.
seeing your presenter, we're seeing
Oh,
your notes. So
oh, so sorry. Let
Oh,
me share to a different screen.
it's a closed caption.
okay, so we don't have any choice about that. That's just it.
Oh, you see the screen and then you just see my closed caption at the bottom, but you can't see
And then it
my.
also, I think, someone's mentioned it looks minimized. Like, I guess
Oh,
the screen looks smaller. Is the
oh,
text
because of the subtitles, I can get rid of the subtitles
probably?
so that would make it easier for people to follow along. Okay. 1 second, I will stop the
Well, I
subtitles.
guess we should ask if anyone needs the subtitles.
Can you all see better now, larger?
There, that did make a difference.
Okay, excellent. So
Perfect.
we see that there's a growing prevalence of transgender identity within today's young people. And then this likely comes with an increase of gender dysphoria. Overall, though, we think that this is a relatively small group of people, certainly a minoritized group. Um, we do know that there's always going to be as like the same amount or less gender dysphoria than there are transgender people. This is a subset of people who have a gender diverse or transgender identity. A subset of those might have this diagnosed mental health problem, gender dysphoria. So it's going to be smaller than this already quite small group. So a combination of exposure to anti-transgender stigma, marginalization, and barriers to accessing kind of like our standards-based medical care, um, kind of add up to just being a very high risk population. And when judged by things like suicide attempts, 30 to 40% of young people in this category are going to have suicide attempts. So incredibly high incidence of suicide here. Sorry. And 60% are going to experience at least suicidal ideation. So something like a 3 times risk for suicidal ideation in transgender people across all ages here. And I just wanted to kind of tease out an important distinction here for people less familiar with the kind of verbiage here. I want to look at the difference between gender identity and sex. So gender identity is a person's innermost sense of their own gender. I am a male, and that's how I perceive myself. And then sex is like the assigned at birth, usually called by a doctor, midwife, something in that space. This is often put on government records. This kind of refers to uh, we think of it as a singular thing aligning chromosomes, hormones, physical, anatomical characteristics, but there's a little bit of variety within sex. But still, for the simplest way, we can think of it as biological male, biological female, and then people who are intersex may have a space kind of between those there. I want to kind of look at like how the notions of gender start to bubble up in a young person. If you talk at 1-year-olds, they don't seem to carry any sense of gender at all. And it's when you get to about 2 that people can first start responding to and identifying basic differences between girls and boys. Then around 3, kids start to first be able to label themselves boy, girl. These timelines vary, of course, as young people develop at different speeds, but in general, this is what we see. And around 4 years old, 5 years old, people tend to have a stabilized sense of gender identity that may persist throughout life. During this 2, 3, 4 kind of run, a lot of young people learn about their culture and their culture's expectations of gender roles, things boys do, things girls do. However, even in cisgender, boys who act like boys and are considered boys, even in cisgender young people, cross-gender preferences and cross-gender play are just a normal part of gender development. So the boy who plays with Barbies may or may not have some sense of being more feminine, but having some interest from the opposite sex is not necessarily a sign of like a transgender identity and is in fact quite common as part of normal play. All children, all keiki, tend to develop a clear view of themselves and their gender over time. So we shouldn't take 4 as like a period at the end of the sentence here. As kids transition into teenagers, we see like a number of changes here. In early adolescence, you start to get your primary and then later your secondary sex characteristics during your teen years. Obviously, there's a little difference in timeline between boys and girls here. The period of development is often characterized by exaggeration of gender stereotypes or by the rejection. This could be a place where a person who had been a female who is tomboyish may lean into an exaggeration of feminine features as their secondary sex characteristics start to develop, or may find that that doesn't feel right for them and may reject or revolt against those characteristics or that identity. In early adolescence, you get these teen boys and they're like bragging about how they're shaving, right? That's an exaggeration. They're really leaning into those sex characteristics. And you have some females who may embrace makeup or other, classically feminine identifiers, at least in the Western culture. And it's kind of like in the context of these changes that young people and their peers that young people may start to feel like a stronger sense of dysphoria or incongruence. If there is especially in this period of exaggeration, if there's a move for some of our peer group towards being hyper feminine females, that may be a point where somebody starts to feel tension and start to see themselves kind of having a different experience than, say, the other girls in that in their peer group. Two just quick comments about this period here. Late adolescence is typically a time of de-emphasized gender stereotypes. Sure, when you first had your, first little bit of facial hair, a boy may really lean into that, and then that's kind of stops being an interesting element of their identity when, say, everyone in their peer group or most people in their peer group are shaving. And then there's also like a sense of early adolescence is just a time of deep insecurity across gender, but across everything. Identity, who am I? Am I cool? Do people like me? And then as people get further into adolescence, it's definitely possible that people can become kind of more secure in their identity across like a whole variety of spectra, including gender. And then this is a time where even like cisgender people feeling more comfortable in their gender expression might be like, a boy who identifies as a guy, he might be like, I'll wear a crossbody bag that kind of looks purse-ish because like I don't have anything to prove. So early adolescence really, in many cases, leaning into over-exaggerating gender attributes. Later in adolescence, feeling as if there's less to prove. Or that's a less interesting part of them. Now, here's where you get into a big controversy, wherein, to simplify the discourse here, there are people who are highly supportive of gender and sexual minorities, and there's a large group of people who have either cast aspersions onto this group or are suspicious about whether this phenomena is real or natural or whatever. And both of these groups tend to emphasize their own bias. And to paint with a really broad brush here, um, persisters, a population of people who've identified as transgender and continue to identify that way, and desisters, people who felt that they might be a transgender person and then later on said, this isn't me. I'm just an effeminate man, for instance. Um, in the group that's highly supportive of transgender people, there tends to be a bias towards saying desisters basically don't exist and underemphasizing the possibility of desisting. And in the gender diverse, kind of like the skeptic community here, there tends to be a real sense that persisters basically don't exist, that this is just a fad or a passing notion for people that go away. And when we dig into the literature a little bit, what we see is that there are both persisters and desisters. And one of the big things that helps us figure out is somebody who says, I kind of feel like I might be a girl inside, and that might be, how I identify. Is somebody going to stick around with that? Well, the earlier on that somebody says that, the more likely that they will have a different experience going forward. But the further somebody is into their life, the more sophisticated they're thinking, on average, the more likely they are to persist with that identity. There's a lot of studies that show like cisgendered homosexual orientation is actually a more common outcome for trans feminine children than persisting transgender identity. Okay, what does that even mean? That means if you look at the youngest people who are assigned as a man or assigned as a boy by a doctor, and they say, I feel like I might be a girl, well, it's actually more likely that they, in the end, come out to be a gay man rather than a transgender woman. So the earlier on, the more likely people are to find other paths or to examine their identity. The further people on, the more sophisticated they are, the more developed they are, the more likely they are to be, in essence, correct when they say that they could be a gender or sexual minority. I want to follow up on one of the earlier risks that we talked about, which is the stigma. So anti-transgender stigma comes from a lot of places, but one of the big drivers is this mistaken belief that like biological sex is a clear binary. There are men, there are women. This is true for all animals, and it's just simple. And in this worldview, transgender people are just simply incorrect, misinformed. They simply just don't know what their own experience is, or they've been conned by the liberal media, some sort of belief like that. But basically, the gender skepticism is to say these people are some variation of wrong. And again, this comes from this belief that there's a clear male female binary. And this makes it feel like gender diversity is just a choice in defiance of this clear male female. Well, I wanted to take a look here at a really helpful diagram from Scientific American, which is widely considered to be a neutral kind of scientific resource, not one that is highly partisan or, engaged in social science. As a matter of fact, there is this tremendous complexity even within what we think of as like biological sex. So I want to zoom in here over on the left side here. We're looking at very, very feminine in the way we think of it at the left and very, very masculine in the way we think of it at the right. And I just want to take a look across the development, right? So at the top of this chart, I'll zoom out for 1 second. At the top of this chart, we're looking at conception. And then as we go down, we're getting further in birth, puberty, and further in life. And what we're looking at is a huge range of different ways people could be if you take culture completely out of the picture. If you just look at what you could see with a comatose person doing a physical exam, there is a huge range between what we think of as classically female human and a classically male human. Zooming in on some of these differences here. So on the very leftmost, you've got a typical biological female, but you've got disorders of sexual development. You've got Turner syndrome. What's Turner syndrome? Well, a person is, instead of XX, they are simply X. They don't have that second X chromosome. So these single gene genetic mutations already take a big bite out of what we think of as all women are XX, period. Well, that's already not true. We can also look at things like single gene genetic mutations, so this WNT4 gene, or if you have the absence of the sex determining region on the Y chromosome, the thing that makes the Y chromosome make someone into a male. If we don't have that, well, you get something that looks an awful lot like what we think of as a female. You could have, say, an XY person, classic male, right? But without that sex determining region, in every way, you would say this person looks to be a female. these really challenge our idea that there's a simple male female and that transgender people are just some variation of wrong, misinformed. Tons of other categories here. Outside of these genetic changes, there's anatomic changes. So we could be born with hypospadias, a change to the male genitals, histologic or hormone changes. So what if you have a body, as many do, that cannot receive androgens, the masculine hormones? So you're like an XY person, and your body is flooded with testosterone and flooded with androgens, and you don't have the receptor for it, or the receptor doesn't work. Now you are an XY man who looks an awful lot like a woman or who presents an awful lot like a woman. Again, we're taking culture completely out of this here and just looking at bodies, but to show there's a huge diversity here. Now we have hormonal factors. So what if you had low T? Is that make you a pure man or something more on the anatomical female side? If you have small testes or you get breast or reduced facial hair or weak muscles, again, nothing to say about culture here, but when you add in that human gender is a complex, culturally influenced concept, just would do well to kind of have in the background here that there are so many factors which shape gender identity, and only some of them are culture. Many of them are what we consider hard medical fact. The presence of testosterone, on average, leads to masculinization. The absence of testosterone, on average, leads to feminization. However, the development of different parts of our brain is like programmed to different degree by androgens, male-ish hormones, estrogens, female-ish hormones. So you, me, we all have this mosaic, patchwork of maleness and femaleness, like literally in our brain. Just like a cisgender normal anatomy person with no variations or medical problems, your brain, my brain, is already a mixture of androgens here, estrogens here. We're already a patchwork, which is to say, we all are. There's additional gender identities which are central to cultures outside of the kind of the mainstream US culture. And as we're kind of getting into the cultural element here, it's really worth it to take a quick sort of fly overview here. There's an abundance of third gender, middle gender identities around the world, and the Pacific Islands are particularly rich here. So I'm just going to take a quick look at this map and just see a great number of gender roles outside of kind of the Western traditional man-woman dichotomy here. So please note, some, but not all of these roles fit within the realm of transgender individuals. These are all gender diverse people. These are all gender and sexual minorities, increasingly popular title that stops the ever expanding LGBTQ and instead encapsulates this group kind of more generally. I've read the phonetic guides here and I've spoken with Olelo speakers and some AAPI people. I've done my best to try to get these pronunciations right, but I'm just a boy from the Midwest, so you'll have to forgive me if I'm not nailing all these pronunciations here. But we have Mahu Wahine of Hawaii and French Polynesia, this Hawaiian third gender people with traditional spiritual and social roles within the culture. In a nationwide survey of transgender and gender nonconforming people, 1 in 5 Native Hawaiian or Pacific Islander respondents had identified as Mahu. So, of gender minorities, 1 in 5 said that this specific cultural influence, the Mahu role, had influenced them. There's examples of genders for people whose sex is assigned male at birth, but who embody kind of female gendered behaviors, like the Pina Pine Ine of Kiriba or Tuvalu. We have the Fa'a Fafine, the Faka Fafine, and the Faka Leti of Central Polynesia. The Faka Saleva Leva, who have traditionally been accepted by Fijian society. The Pau'oana of Micronesia and Guam. The Akava Ine from the Maori tradition in the Cook Islands, and the Whaka Wahine of New Zealand, the Maori tradition. Continuing westward, we find the Waria in Indonesia, the Be'o and the Bakla of the Philippines. Many, many more examples of traditional gender roles exist throughout the Americas and beyond. Here in Hawaii, counting only public school children, which are kind of like the easiest to talk to, we find about 1,300 transgender high school students, or it's about 3% of public high school students in Hawaii. Now, here's some grim stats. Transgender youth in Hawaii are one-sixth as likely to get as enough sleep compared to their cisgender peers. They are one-sixth as likely to eat breakfast most of the days. They are one-sixth as likely to meet their physical activity guidelines. What is going on here? Transgender youth are significantly less likely to visit a healthcare professional, such as a doctor or nurse, compared to a cisgender youth. You can imagine things like fear over prejudice, fear over being misgendered, fear that somebody will lack the kind of necessary knowledge to understand their culture or medical background and how it affects basic things like what organs they want you to keep a look at or what medical problems they could be at higher risk of. As a physician, as healthcare workers or mental health providers, as community members, it's our role to accurately identify. I'll go to medical providers for a sec. As physicians, as medical providers, it's our role to accurately identify biological sex and to support patients in identifying their gender, a process which might not be like just one and done, but might be ongoing. So we're trying not to pathologize different ways of being. You don't go to your doctor and get diagnosed as a person of color. And in the same way, you wouldn't be diagnosed as a transgender person. But we do want some kind of a diagnosis in the mix here for reasons we'll talk about a little bit more. So, transgender identity, not a psychopathology, not a mental health problem. Just like being gay or lesbian, you shouldn't be considering that like a mental health problem. And as part of this, as part of moving away from a pathologizing kind of approach, we're starting to use phrases like gender diverse instead of like gender nonconforming or other kind of ways of saying that there's like something wrong here. Gender diverse just speaks to the diversity of these people. After all, medicine has this really problematic history of diagnosing queer people with mental illnesses, starting out as like an unrecognized phenomena, just like what is this? The DSM-1, the DSM-2, don't even know, no mention of it. By DSM-3, we've got sexual deviation being like the official stance on what's going on here. We had transsexualism and gender identity disorder of childhood, both as like mental health problems. And then there was a revision to the DSM-3 that separated the desire for surgery from the diagnostic criteria. So at least started to recognize services that these people wanted. But ultimately, this is really looking at like, these people are sick. How do we fix them? So then we started to, in the DSM-4, we started to move away. So we took transgender related disorders and we moved them into a category with sexual dysfunctions and paraphilias. Okay, that's not great. Paraphilias are things like what lay people would call fetishes. So not a great category here either. Perhaps has some similarities, but it's sort of a problematic grouping. I just want to like get back to the point I raised earlier. Like, should this, he says, gesturing widely to the whole idea, should this be in the diagnosis book? Well, I think probably in some variation. I live in America. And in America, if you want to get insurance to pay for a thing, which is basically necessary for all non-oligarchs, if you want to get insurance to pay for a thing, you need to have a listed diagnosis. If there is no listed diagnosis, in general, you are not getting your services reimbursed. That is to say, if you take gender dysphoria or something like that out of the book entirely, what you're left with is people who want to get $10,000 fertility preservation measures, people who want to get highly expensive surgeries, and you're just telling them to pay cash. There would be a huge queer tax imposed upon these people if you got rid of some diagnostic consideration. So, how do we square that circle? We said, you, queer people, are not the problem. We're not diagnosing you here. What we're saying is some queer people do have a problem where it really pains them to be how they are in the society they live in. We are helping with that pain. Also, I need to list this as a diagnosis code so I can offer you therapy and help you with other stuff. Without the code, you don't get the healthcare. So probably need something there. Now, looking at the new International Classification of Diseases, the ICD-11, they're actually talking about removing gender incongruence from mental disorders entirely and putting it in a different category. So there's some movement there. Now, things like anxiety, depression, suicide thoughts, or suicidal attempts are just way more likely in young queer people. Serious drug use is way more likely in young queer people. I want to think a little bit about what a transition might look like a little bit, just kind of bring you into the space of somebody going through this. So let's take somebody whose doctor said they were a boy at birth. They come into you and they're starting to say, I think I feel that there's something different within me than what the other boys in my class, in my community, in my church, whatever. There's something different about how I feel, about what I want, about how I see my body, about what I think I should look like. There's something different happening here, and I want to talk about it with you. Well, this person may choose to explore the space a little bit. Maybe they say, instead of, whatever, can you call me Sam? Can you call me Sarah? Whatever. A nickname, as so many children try out, maybe a permanent or maybe a temporary part of how they see themselves. They may also say, could you call me her instead of him? Could I wear that shirt that was purchased from the girls' clothing section? Could I try changing my hair? We think of these as social transitions. This is the tryout. All of these things are 100% fully reversible. And this honors the fact that a person comes in and they're not even often strongly asserting that they're a transgender female. What they're saying is, I'm confused. I don't know what's going on here. We explore the space, and if they say that what they feel is that when people call them he, that it hurts them, we say, what if we tried out people calling you she for a little bit and just see what that was like? We explore the space in fully reversible ways so that if they're like, well, I tried that out and no way. When people call me her, that's so weird. I'm a boy. If people, say that doesn't fit them, well, of course, then we don't proceed. I mean, they usually would choose not to proceed. And I just want to be super clear here that this is like a supportive process. There is no vision of having worked in multiple clinics where gender and sexual minorities get services. There's no like vision or efforts to persuade people to live in one way or another way. It's more like we explore the space together, we see what might be helpful, and present, hey, some people who feel the way you feel have tried this. Do you think that would be helpful for you? So they explore the space, they might change some reversible stuff. Now we get to puberty. The big problem with puberty for people who are, say, transgender is they start to have a lot of physical features that change their body. And puberty can always be a stressful period for young people. But for young people who are transgender, the development of incongruous sexual features can be really distressing. And it causes these people to feel so much distress that they are highly at risk for suicidal thoughts and suicide attempts. If puberty that starts to really emphasize sex characteristics that don't match their inner feeling. If puberty is starting to put people into a dangerous place, sometimes endocrinologists, hormone doctors, pediatricians, sometimes physicians may say, we need to take a pause. If you go through puberty right now without the skills you need to deal with it, you could die. So that's not great. There's some risk, some benefit. Maybe we try once somebody has started puberty, the earliest stage, which we call Tanner stage 2. When someone has first started puberty, maybe we stall for time. Maybe we teach them better coping skills. Maybe we are going to help them explore the space better. Maybe we're going to help them have more important conversations, better understand some of these words and what their choices look like. But we stall for time for like up to 2 years using the same medicines we use for other kids who have puberty that comes too early. Because puberty is a chain reaction, stopping the early steps of puberty can place the whole transition on pause, which is okay for up to 2 years. And then after that, usually this is no longer an option. Then you have somebody who's like an adult. In most jurisdictions, we're talking about an 18-year-old here, somebody who's now an adult and who, having stalled for time, maybe has learned more coping skills, better understood their situation, better understood the words to describe their spot, and maybe an adult may choose to pursue things like a hormone-based transition. They may choose to use things like anti-androgen medicines or anti-male medicines that reduce some male features. So um, at some point, they may also not go this way. You get to step 2, step 3, step 4, whatever, and maybe you desist. You say, I was exploring the space and this actually isn't right for me. I don't think this is my path. That happens all the time. And that's always something that we keep open, something we, pull back to in our conversation to make sure if someone is feeling differently, that we explore that with them and help them head in the direction that continues to be most appropriate for them. Really quickly, I know we're not all prescribing medicines here, so I just want to like fly through this part, but 17 beta estradiol, which you usually think of as estrogen, the feminizing hormone. You can use estrogen, just boost someone to be more estrogened, especially as an adult. You make them have more female features. Some of the male features don't really go away, some kind of transform over time. However, the old school way of just flood with estrogen has now been replaced by usually a combination of estrogen and an anti-masculine, a medicine you take by mouth. Spironolactone, which is this medicine we found actually kind of reduced maleness in people who are taking it for blood pressure. So nowadays, we use things like a combination of estrogen and an anti-androgen medicine. So a more female injection, a less male medicine by mouth helps you get away with fewer medicine overall. This is a popular choice and is actually the number one medicine used in the United States by queer people, by trans women specifically. Low cost, high effective, doesn't involve an injection. There's other things like finasteride. You may have seen these commercials for people like losing hair. This blocks male pattern baldness, which, like, if you are a trans woman, male pattern baldness would pretty much be the thing that would push you over the edge. So a lot of people don't want that. Sometimes you get things like that in the mix. These were these puberty or these are our GnRH agonist medicine. So this is sort of like a preferred, really helpful medicine for people who want to affect their kind of gender expression. But this is a sort of expensive choice. So these things like spironolactone, which are really affordable, are more often used here. I'm just thinking about the strength of evidence because this is a hotly, contested space, and there are allegations that there's really low strength evidence here. Part of this comes from the difficulty of studying things in young people. Part of this comes from the difficulty of saying we've got 100 kids who are at high risk of suicide because of their transgender identity. What if we gave half of them sugar pills and we gave half of them life-saving gender affirming care? It's really hard to run an experiment like that where like half the kids are at risk of dying or something. So it's hard to run some of these experiments, and this has weakened the evidence. Some clever researchers are trying to get better evidence, but it's fair to categorize the current evidence in the youngest gender affirming care as on the weaker side compared to other domains. When you look at evidence from transgender adults, we do see and these are uncontrolled prospective cohort studies, which is not the strongest format of study. But based on this 250 adults, we do see hormone therapy may lead to improvements in psychological functioning, so better mental health here, better kind of getting more out of your brain. There's not very good like long-term studies looking at hormone therapy beyond 18 months. And many people do use these for much longer than 18 months. And that's for sure something that's necessary, especially when you look at, well, how does this affect the brain? How does this affect cognition? These are very important things to continue to look at. We do know that hormone replacement and breast augmentation do decrease suicidal thoughts in trans women. But unfortunately, when you look at trans men, we don't really see that hormone therapy has been proven to make suicide any less common. So we'll sort of say the strongest evidence for gender-forming hormones are in trans women. Another study showed statistically significant kind of medium-sized reductions in distress, in smoking, and in suicidal ideation for people who got gender-affirming surgery. So there's some benefits there. In 2018, Hawaii became the 12th state to ban sexual identity change efforts, aka gay conversion therapy for minors. What we know right now is that attempts to engage individuals in psychotherapy to change their gender identity or expression are currently not considered fruitful. You hear this absolutely all the time. Somebody comes in, they're a 16-year-old, and they say, I'm a boy, but I think that I am actually a woman. I'm a trans woman, and here's how I feel. Lots of people are like, cool, get a bunch of authority figures and just tell them you're wrong and tell them how to cope with being so wrong. And like, I assure you, it has been extensively tried in every variation. You just cannot therapy these people to convince them that they're wrong, whether you think that's really plausible option, whether that always sounded like a distasteful option to you. Simply, nobody has ever put together a halfway decent protocol for convincing these people that they're wrong. Any variation of therapy, change their mind, any of that just doesn't work to reduce these people's risk of suicide, doesn't work to reduce their anxiety, doesn't work to reduce their depression, and barely, if at all, works to change their identity. So a lot of people strong urge, what if we just got all the authority figures in their life to just kind of say over and over again, just stop saying that. You just stop saying you're a girl, dog. Everyone's a boy, and you're just be a boy. It just doesn't work. No one's ever figured out a way to make that work. So it's illegal. It should be illegal, and no major medical associations in America support that. Um, Medical goals. So talked a little bit about male to female here. So we want to maybe reduce facial hair or body hair. That could be really stressful. Some people want to induce breast tissue growth. That can happen kind of over like a year or two. Maybe we want to change to have a more female body fat distribution. We want to atrophy, shrink, or minimize the testes or the prostate. And some people will choose to get things like genital reconstruction surgery exclusively for adults. But these could be things like orchiectomy, which is our bottom surgery. Um, this isn't really going to have an impact on the voice. If you were born a man and you've got a deep baritone like me, then you might need to work with a speech pathologist, for instance, if you would like to change what your voice sounds like. Other things like we don't need to get like medicine involved for all these things. Like if somebody doesn't know how to shave, then what they need is like a role model who knows how to shave, or they need laser hair therapy or electrolysis or things like that. There's also stuff like, well, yeah. People can benefit in a lot of these spaces from having people who have lived as a female for a really long time who like, oh, a lot of people who are living as a man never learned how to shave legs or whatever. And having someone who knows these things can be really helpful. So strong role models can be really helpful in this space. For people who are a female transitioning to male, maybe we want more facial hair, more body hair. We might want things like binding of mastectomy or breast. We'll get to that in a sec. A male body fat kind of distribution, and some will choose genital reconstruction surgery. The cheapest option here is binding. So breast binders, cheap fabric options that reduce dysphoria without any medication side effects. These are the best. And if you cannot afford these, if you have a young queer person in your family, community, one of your patients who cannot afford these, organizations like Point of Pride will donate gently used binders and mail them to the House of Young People so that they can have this cheap, at times life-saving intervention to reduce dysphoria. Now, I work a lot with families, with young people. You'll have a young person who said, I've known since I was 5 that even though they always call me John, I've been more of a Jamie. And I'll have a young person who comes in saying, I've had this inner feeling for quite some time. And they're like, why can't my parents get on board? What's wrong with them? And one thing I talk about all the time with these people is you have had a lot more heads up here than the other people in your life. You've probably been Googling this, you've been discussing this with your friends in ways that the other people in your life may never be having these conversations. They may not be in the same online spaces learning about these things, but at the core of it, you've just had this sensation much longer. And I want to just talk about here something that's a little bit verboten in kind of the cultural left in discussing this, which is it is okay for parents to mourn the expectations they had about their future. What do I mean? If you've been spending the last 10 years dreaming of little John in a tuxedo and how awesome it's going to be, and he's going to be coaching a little league team, and you've got all of these visions, and then John says, "No, I need you to treat me as a woman. I need you to call me Jamie." A lot of people understandably mourn the specific vision they had of the future. And that is okay. You can still love your child and still want the best things for them. And that might not even involve fully understanding their own vision. But it's okay to mourn the specific view you had. And what we hope, what we work towards as supportive community is, well, can we get to a place where we're also celebrating that your child is now going to wear an awesome wedding dress? And, there can be an adjustment there, but hopefully you come to a place where it can be a way of supporting a young person here. I want to think a little bit about something I mentioned in my answer to this question before we started here about kind of the leapfrog approach or about coming out. Um, Hawaii is relatively safe as a state for queer people to come out. I was born and raised in Missouri, where it's more often that people could be like literally killed for being a queer person. And as a provider, we need to understand that it is not universally safe for people to come out. There are communities, there are cultures, there are settings wherein it can still dangerous to come out as a gay person, but especially perhaps as a transgender person. If somebody wants to come out, the first view is where is it safe to do so? And the young person, the queer person makes that call, not us. But let's say somebody does say it's time for them to come out. They've got a family member who knows and a family member who doesn't, and then none of the aunties and uncles and grandpas know. You can use the leapfrog approach. So you have, say, mom knows and dad doesn't. Queer young person and mom have a conversation with dad rather than throwing, young person to the wolves and having them navigate that conversation by themselves. Have someone who can answer a question or just be there to hold a hand with you. And then instead of throwing your young queer person to the wolves, talking to auntie who grew up speaking Vietnamese, doesn't have any sense of this culturally, instead mom and dad and queer person can navigate that conversation together. And in that way, you can use your family to leapfrog and have these conversations with your school as necessary, or your faith community, or your larger, cultural community. So use the safe people you have both to look for the safety of expanding the circle of trust and the circle of knowledge, and then also use them materially as like good people to have in this conversation. I'm gonna just really leave this part to the medical providers here, but we'll just say like there's a lot of medical monitoring going on here. The medicines that are used in medicine in general have upsides and downsides, and those need to be discussed with people. Risks for the worst conditions need to be monitored, often including laboratory testing here. So we're looking at things like checking our potassium with the medicine that affects our potassium. So we're also going to look for things like if we're worried about changes to how thick your bones are or other things. I'll just point out here that like if somebody is born a male and then they're like living as a female and they're using female hormones and they're fully trans woman, like oftentimes they still have a prostate and can still die of prostate cancer. So it's hard to navigate. But like if somebody has an organ, you need to do all your regular doctor biz with that. You need to follow in and do all your regular monitoring and all of your regular health care for whatever organ somebody has. As our conversation has hopefully demonstrated, there's a lot of different components here to giving effective care to one of Hawaii's most at-risk groups of young people. Generally, guidelines agree. We got to collaborate. We got to get primary care, hormone doctors, maybe obstetricians, psychiatrists, or other behavioral health workers. Maybe you're getting surgery teams or others kind of like all come together and work together to try and reduce the risk for these people. Pull in social work, pull in faith community, get the school services involved. The more people you have supporting a young person, especially a highly vulnerable young person, the better odds, they may have of having a good outcome. Within healthcare, we should like make sure our staff know where you'll mark it down. If someone is, say, named John, but uses female pronouns and other kind of like potential tripping hazards, right? How are we going to communicate about that? What do we do if someone says they want this, they want to be referred to this way? If you frequently work with people in this community, you should have some sense of like who in your community also works with this group and who can you refer to. If you know how to help this community, fantastic. If you don't, you could at least know who does. So your answer is not like, sorry, good luck, but could be like, here's how I can help connect you with someone who vastly reduces your risk of dying by suicide, for instance. So just like a variety of different things, the whole squad from the pastor to the Sylvia Luke, who helps with name change, Lieutenant Governor, or the medical team. So maybe you try to see, is this a gender diverse person? Do you diagnose them with gender dysphoria? Are there other problems? They have an anxiety disorder. Are they shooting heroin? Are they a good candidate if they wanted to? Like, is this a person who could use hormones? Are they of age? Are they of a solid, financial situation? Do they have the right support? Are they unhoused, right? Looking into what kind of interventions could be helpful. Do they have the capacity to make this decision? Like, if a person is psychotic out of their mind, or if a person is actively high in cocaine and maybe they are really transgender and they, whatever, they come in and they're like, yes, we're getting a gender affirming surgery. It's like, well, how about we schedule to see you next week? Because I can't sign on to this right now. You don't have capacity to make an informed medical decision right now. We can also talk to them about what therapy can and can't do. Therapy can help reduce your anxiety, can help you better understand how to navigate your community. It's not going to try to, and it won't be able to. make this sensation go away, but it can help you deal with it. It can help you deal with other tough sensations and help you be safer, lower your risk of suicide. We can try to make sure that the family knows what's up and make sure that other providers are aware of the care that we're doing, changes to our medicine, just the usual good stuff. There's a lot of more research that's needed here. And again, this is a highly controversial space. So efforts to get this research funded are hotly contested. Efforts to do this research are hotly contested, none the least because the proposition of taking Hawaii's most high risk young people and depriving them of medical care to run a science experiment on them is something a lot of people feel really gross about and find it really challenging to navigate. So it's quite difficult to do some of this research still, especially when it comes to adults, which are easier to study ethically. We really do need to look at what are estradiol and testosterone's effects on cognition or mood. I'll say especially as estrogen and especially as testosterone for just cis dads, just like a man who has low T and wants to get testosterone. As that phenomena grows and grows in our society, we really, really should be looking into this. Even people who just don't care at all about queer people here, we just need to know what happens when, say, a person who's born as a man takes a bunch of testosterone. What does it do to our brain? What does it do to our heart? We've done some of this research, but there's a lot more needs here. We should also get a better, clear view of the persister to sister ratios here, just like when someone says that they think that they might be a transgender person, how likely are they to be right across different age groups, and getting a better gradient would be really helpful there. And then there's some use of antidepressant medicines or mood stabilizers or antipsychotic medicines. And right now we haven't really proven that any of these are that helpful for gender dysphoria. If a person is transgender and depressed, use antidepressants, yes. But we haven't really figured out if there's a role for the mental health medicines here. And I think that's something we definitely need to answer. So something we'll of course look into. If you are curious, I find the Center of Excellence for Transgender Health to be a fantastic resource. This is a San Francisco-based organization that really provides great resources for providers, for families, for communities. And I will just say they are a non-government resource, so they still exist online in a way that unfortunately a lot of government-based research is sort of disappearing. So this has been my presentation. Thank you all so much for listening today. Happy to answer any questions. I know this is a topic that's been a lot in the conversation, in the culture, and I really appreciate you all listening. Happy to answer any questions. And again, thank you for being here.
Thank you so much. It was nice to hear about it from the process that people go through as well as the provider side. So that was really helpful.